in my clinic, I had a lot of questions related to testing that weren't about diagnostics, and one of those was monitoring. So when I was here in Oxford at the Centre for Evidence-Based Medicine, we started work that Patrick was also involved in as well, on how to go about the process of evaluating and developing monitoring techniques. And I think this is still sort of early days for the area of monitoring, but I just wanted to give you a bit of an overview of the things that have happened in the area. So how I first sort of recognised the need for the area is when we started a program grant on looking at diagnostics. We actually got people to record why they were doing certain tests. So this was just a bunch of clinicians within the research group. And they kept a log of it, and these were the reasons they gave: diagnosis, monitoring, screening, prognosis, treatment planning, which might be sort of imaging of something to tell where the foreign body was, and a particularly honest GP told us that they used it for stalling for time. So I'm going to talk about number 2, the monitoring test, but in case you're interested, the stalling for time has been implemented in some places like St Elsewhere's as a special pathology ordering form of the serum placebo level. It's important not just to have the stalling for time test, but you also need to be able to tick the box to say when you want the result back. So you can say, oh, this is a very complicated test. It'll take ages for the test result to come back, and there should be a never box on there as well. But I'm not going to talk about that anymore. I'm going to move on to monitoring. And just as some examples of monitoring tests: cholesterol, HbA1c, INRs, which are the prothrombin times, urinary albumin and protein, creatinine, the EGFR, thyroid function, drug monitoring, and there's a very long list of the common monitoring tests that we do. Of course, some of those things are done for diagnostic purposes, but actually the major volume of these tests is used for monitoring purposes, which we haven't developed such good techniques for evaluating. I'm only going to talk about 3 of those examples, the top 3 there: cholesterol, HbA1c, INR, and I'll look briefly at B-type natriuretic peptide as well, just to illustrate some of the principles and difficulties in looking at monitoring. Just to give you an idea of the growth, this is a study we did in Oxfordshire, which fortunately had records of their blood tests going back over 20 years. And we mapped out the number of cholesterol tests being done. And what we found was this enormous growth. You can see there's a flat period initially in the early 1990s where the BMJ had actually published a moratorium on doing any more with cholesterol treatment, and then it's flat for a little while. And then the 4S trial comes along from Sweden, the first big statin trial. And then there was a series of big randomised trials published then, and you can see this rapid growth in cholesterol testing. We actually broke that down by how much of that was repeat testing within a short period, and in fact the majority of that testing was repeat testing. So it wasn't trying to diagnose people with hyperlipidemia, it seemed to be people doing this. So it's about a 10-fold growth at least in cholesterol, triglyceride and HDL testing over that period. So probably a lot of other tests that have grown rapidly during that same period. Another one would be blood glucose home monitoring. A little bit of the history of this before I come to the specific example I wanted to talk about is in 1975, the first pregnant patient persuaded Clara Lowy, who was the obstetrician taking care of her at St Thomas's, to do home monitoring. She said she had to be brought into hospital in order to, because she was diabetic and she was pregnant. And she said, well, what can you do in hospital that I can't do at home? And they said, well, measure your blood sugar is one. And she said, well, can't I do that at home? So she got one of these very primitive machines. They trained her. These were the old colorimetry machines that you had to read off very carefully. It took about 20 minutes to warm up, etc. Very primitive technology, but she managed to do it successfully. And then in 1978, there was actually a case series showing better control with the women who'd done home monitoring versus the usual bringing them into hospital monitoring, and they like it much better to be able to monitor at home. Women hate coming in during pregnancy to be in hospitals, makes them feel ill. That then moved to say, well, actually we should be doing this home monitoring with patients on insulin, because what you're doing the home monitoring for is to adjust your insulin. You get a high blood sugar and say, well, I've got these high blood sugars, maybe I should change the amount of insulin I'm taking. And the big DCCT trial which actually was a package of things, but a central part of it was this home monitoring of blood sugar, showed improved control but also outcomes in insulin-dependent diabetics. But then we generalised that whole thing to say, well, maybe all diabetics should be doing this, and the guidelines suggested that was an appropriate process. So in 2008, the costs of this worldwide were about $8 billion, and Andrew Farmer told me that's continued to grow. It's $9 billion at the moment per year, so it's a very expensive thing. So how effective is it? Well, the HTA program in the UK decided to do a trial eventually because all of the trials had severe weaknesses to them before this. And this was the structure of the trial that Andrew Farmer in the Department of Primary Care here led. They got diabetic patients who weren't using insulin. They gave them all the same diabetes education. That's really important because that confounded a lot of the trials that had been done of home monitoring. That they were not only home monitoring, but they were also other care, which included this patient education. They all got the same education, then they were randomised to 3 arms. Less intensive control, home monitoring, more intensive home monitoring, or simply a haemoglobin A1C is the only monitoring they had, and that was done every 3 months. So randomisation to those 3 arms, 150 patients in each arm roughly, and 12-month follow-up using the haemoglobin A1C as the outcome, and here's the outcome. So the graph up here shows the difference. The scale's not very wide because there wasn't very much difference. In fact, it was not statistically significant and it wasn't a clinically important impact. But there was some suggestion that there was worse quality of life, in particular increased anxiety, which unfortunately the other studies haven't measured, so we don't know whether this is a real finding or not. But that one I think needs to be followed up. But there's this possibility of no clinical impact or a very minor clinical impact, perhaps increased anxiety and a very high expense to this whole procedure. So maybe we shouldn't be doing home monitoring. Very important, cost-effective trial to be done, of course, because it cost about £0.5 million, which sounds expensive, but if you compare that to the cost just of the test strips being used in the UK, that was about £100 million per year. So it's about 2 weeks of test strips. And as I say, the worldwide cost was about $8.2 billion. And I'll mention that Andrew Farmer's actually led a systematic review, an individual patient meta-analysis of the 6 randomised trials that qualified, and he found in that a just significant 0.25% difference. But again, it's probably not a clinically important difference, and we don't know whether it outweighs the anxiety or whether it's worth the cost. So, summary of those findings, yes, probably works for pregnant diabetics, people using insulin, but at the moment at least, probably not useful as a routine thing. So these were all routine monitoring. There may be occasions when you do want to monitor patients who are not on insulin to train them in their education process for maybe brief periods. That's an unanswered question. But as a routine, long-term, ongoing thing, at the moment at least, I think that the jury's pretty clear that it's not a particularly useful thing to do for most patients. So why is that the case? Well, a simple model of monitoring is that you need a valid and accurate measurement, you need an effective adjustment process, and you need some informed interpretation of that. Because what you're doing, you've got to do something with the monitoring in order for it to help patients. Now, what do you actually do with home blood glucoses? Well, as a GP, I know what happens with those. When the patient brings me in the record of home blood glucoses, I look at them and I know they haven't written them down if they're particularly high. In fact, I know they probably haven't measured them if they've done something naughty. So that the book I know is inaccurate. They haven't made any adjustment of the insulin because they're not on insulin. They don't adjust their oral hypoglycemics either. So what do? I look at the hemoglobin A1C and I adjust any therapy based on the hemoglobin A1C, which I think is more accurate than their booklet. So this, even though you have a valid and accurate measurement, this other parts of the loop are really broken. In particular, there's no effective adjustment occurring because there's no action taken that's based on those measurements. It's based on something else. And that's where the loop is broken. Okay, you might contrast that with my second example, which is the self-monitoring of prothrombin time, the international normalised ratio for warfarin. So the usual care for this is that you get your blood taken, gets sent off to the lab, it gets done, somebody at the lab looks at it and they phone you up and tell you what the result is. And that is slightly complicated because then, particularly if you're travelling, this makes things difficult. But it also just is complex in terms of the number of people involved. Home monitoring is a lot simpler. It's a device like the blood glucose machine. You can get your INR measured at home. It has a readout like this. So this person's in the normal range. They're 2.9 when they should be between 2 and 3. Everything's fine. And with some of the trials, as you'll see, they actually adjust their own warfarin as well. So they complete the loop, that loop that I just showed you, within the home and immediately as well. So there's very quick feedback. So I'll apologise for putting up the old review of this. It's just that the new review has many more trials and is too complicated. I couldn't fit it onto the screen properly, but they show roughly the same thing. And that is, there's actually a decrease in cardiovascular and all-cause mortality with the use of home monitoring versus usual care. And this is high-quality usual care, by the way. In particular, it seemed to be better for the self-adjusting group. So you could do the home monitoring, but then you've got a clinician to help you adjust it. Or you could monitor at home, do the test yourself, but also adjust your own levels. And I'll show you one of the nomograms that patients use for doing that in a moment. For hemorrhage, which is the downside, now you might think, well, patients are actually doing better in terms of their clot outcomes, but maybe they're actually over-adjusting themselves. They're staying too high, and so they're having more hemorrhages. But in fact, there was no significant difference in the hemorrhage rates. So they're actually just keeping themselves in better control. It's not all patients that can do this, of course, but you imagine that you had to anticoagulate yourself on warfarin. You know you're walking this fine tightrope. Patients who learn how to do this can do a better job than we can do, basically, because they're intelligent people who you've trained up and they're much more interested in the outcomes than we are. So they do a good job. So they've completed this loop, a valid and accurate measurement, an informed interpretation, an effective adjustment, particularly if they're doing it themselves. And this is one of the sorts of charts that you can use that the patients had for adjusting their own warfarin, which I'll blow up for you. It's divided up by dose like this. So green is good, you're in the 2 to 3 range. Yellow, you're getting a bit outside it, but they tell you how to adjust. And then the red zone is you better call somebody, you're in the wrong zone at the moment, and you need somebody to guide you back into the green zone. I'll put circles on here to say how much would you actually adjust if somebody was in that range and they're on 3 milligrams. And most people over-adjust. It's a big problem for clinicians because they don't take into account that a lot of the fluctuations you see are just noise. So it's actually a fairly small adjustment here of 0.5 milligram if you're out of range in the 3 milligram one. And for the over 3 milligrams, it's a 1 milligram adjustment. And that's a big problem with all monitoring, is that we tend to over-adjust. You need to bring it back in slowly and carefully. Otherwise, you can actually increase the amount of variability by over-adjusting, paradoxically, which Deming pointed out about 50 years ago. And just before I finish on the warfarin monitoring, some people have been suggesting that, well, maybe with pharmacogenomics we can actually do away with a lot of this monitoring. We just know your genetic profile, we can work out how much warfarin you need, and that's it. Well, didn't turn out that way. This is a systematic review of the 3 trials that tried doing that, and it actually found no statistically significance in the bleeding rates or time within the therapeutic range. It did predict accurately how much warfarin, about 50% of the variation in how much warfarin you needed, but then to get the remaining 50%, you needed to be adjusted in any case. So while there's an initial gain in sort of guessing your first dose correctly, you still need to get down to your final dose and ongoing doses based on long-term monitoring. So the gain from the pharmacogenomics here at least was not enough to overcome the intrinsic variability and ongoing variability that occurs with changes. I just want to mention BNP as well, just as a 4th example of the problems of monitoring, because it illustrates another part when you're trying to evaluate monitoring, which is what is it that you're evaluating, which comes up in diagnostics as well. It's the whole pathway that we've been hearing about as well. So here's the first study of BNP monitoring of treatment in heart failure done by a New Zealand group, Troughton in the Lancet. Fantastic difference in the event-free survival. You can see here that's statistically significant, even though it's a fairly small study. Of course, you always trust very small studies that come out early, the first one, because they usually are gazumped by other studies later on. So there's the first Troughton one you can see. Do I have a pointer here? I'm sure you can all see it up here. And then the other studies were a bit more conservative. But actually there is an all-cause mortality reduction from the BNP-guided therapy. But I think one of the difficult things that the group in Oxford here at the Maddox group is currently trying to untangle is that really due to the BNP? Because if you look at the studies, it's not just BNP-guided therapy, it's often structured care that goes along with that, about increasing the doses of medications for heart failure. So it may just be a way of getting people to give better structured care and increasing the amount of ACE inhibitors, etc., that they're giving. But trying to untangle that is an ongoing challenge. But it's something you need to think about when you're thinking about the comparison between a monitoring strategy and an alternative. Is it a pure comparison, as we saw with the diabetes one, or is it confounded by something, as we saw with diabetes, where it was education? Okay, Patrick, I've got another 5 minutes. Okay, so I'm going to finish on talking about intervals as well, because I've talked about the sort of black box approach, if you like, to evaluating monitoring strategies and when they didn't work according to that theoretical paradigm of the three things that you needed. I also want to talk about a little bit of work of trying to decide how often you need to monitor and what sort of a global strategy you needed to take, because that really needs to be optimized first before you go and do the randomized trial. You want to get the right test with the right interval, the right interpretation of it. When you've worked out those things, you're ready to go to the trial. If you do it too soon, you're wasting your time. So it's a bit like doing all of the pharmacokinetic and preliminary studies for a drug. You need to do the same thing if you're going to study monitoring. And I just wanted to point out there are three basic strategies that we can use for monitoring. I'm really going to talk about the third one, and they're fire and forget. That is, you don't do any monitoring at all, and we're used to doing that with things like aspirin or short courses of antibiotics. We don't actually monitor anything. We don't monitor people's platelets. Well, it's been suggested. And we don't do it with antibiotics. We can do fire, check and forget. So one example of that, or potential example, though the evidence base for this is a little bit weak, is where you do an aminoglycoside, where you give an initial dose, measure the trough, and then you adjust the time interval between doses according to that first dose. So that's a fire, check and forget. But the one that we do most and where all the action is in monitoring is fire, check and recheck. And you could do trials that compare these strategies, of course. And I wanted to point out is, if you're going to do a fire, check and recheck, it's usually for things that are a gradual drift, where there's a modest change, not a sudden change. You can't detect sudden changes with monitoring. It would be a bit like asking, will my tyre be flat tomorrow, where you get a sudden flat tyre? Okay, who checks their tyres every day before they go? No, okay. So your monitoring interval, if you wanted to check a flat tyre, would basically be almost continuous, and we do that just because the car feels funny when you drive. That's how we actually do the monitoring. And what we're really doing is to try and detect the sudden slow change. And that's important because if you're thinking about sort of trying to monitor for peak events like people suddenly stopping their medication, you're not going to pick most of that up with the sort of monitoring that we can do, which is this slow change, which I'll illustrate with cholesterol. I think of this as sort of like a tortoise race. Now, there's a very slow change over time with your cholesterol or your blood pressure or many of the things that we monitor. But the important thing is that there's not only a slow change over time, but there's some variation. There are slow tortoises and there are fast tortoises. Some people won't have changed at all, and some are going at a faster speed. And we have to try and detect the people who are going out of range against this background of a constant fluctuation. So we need to think about what we call the signal-to-noise ratio. The noise is this within-person variability, the day-to-day variation. The signal is this gradual drift out of range. My INR is going out of range, or my blood pressure is going up. It'll happen gradually, and what we need to do is compare how fast that can happen with the fastest tortoise compared with that background noise. So we did that using one of the statin trials, looking at how fast people on average went out, and it was actually a very slow drift, going from 4.49 to 4.63, so a very tiny change over 5 years, but with some variation. But getting that variation is actually slightly tricky, because this is the within-person variation. The top one here shows the total variation, which is a combination of the range of the speed of the tortoises, if you like, combined with the within-person variation. So what we need to do is remove the yellow distribution, the day-to-day fluctuation, from the total distribution of apparent changes over time. And with that, we can work out the rate of the slowest cholesterol rises, which was virtually 0, compared with the fastest, which was still only about 0.3, was the sort of range of cholesterols over time. And because of that, we suggested, well, actually, you probably don't need to monitor cholesterol that much. A lot of what you're detecting is actually just noise. It's the within-person variability. It's not a true change in people's underlying cholesterol. And it might be reasonable. We worked out the error rates of this and compared them and said probably for most people you wouldn't want to check or recheck within about 3 years to see whether you needed to change treatment. And some people would argue you can just fire and forget. I know people within the clinical trials unit here would argue that all you need to do is make sure people are taking their medication. In case people think you can do this to detect changes, we again showed that you can't detect compliance because of the noise of the intrinsic noise, the range of variation. One of the things we didn't do, and we probably should have done, was do that by the initial level of cholesterol. So I'll just illustrate this coming back to the hemoglobin A1C example from earlier, but this is for screening monitoring, or pre-treatment monitoring, I'll call it, rather than post-treatment monitoring. As an example of another plot that you might do is how often should we rescreen for diabetes. If you have this, threshold of 6.5, then that's basically based on these different strata. This is the people who are between 6 and 6.5 initially. So you see this big blip, which is probably measurement error, or mostly people who are close to the threshold in the first year and then a rise thereafter. But for the people who are below 6, almost none of them over the 3-year period went above 6.5. And we think you should do this for a lot of things where we're monitoring, particularly pre-treatment, is stratify by how far away you are from the threshold. If you're a long way away, you don't need to recheck for a long time. It's true for a lot of things. Just to point out then, some of the downsides of monitoring we've seen are the false positives, the anxiety that you induce in the patients with diabetes, not only from their false positives, just the process of monitoring, and also the costs of this. As I said, this is probably about 50% of all the tests that we're doing now. So it's actually a very high cost component that has been under-evaluated. And this is a cartoon by Hilda Bastian about Dr. My Self-Stalker, 5,000 app detected pre-diabetes to illustrate the anxiety problem. That these apps and ways of monitoring at home now have become incredibly popular, and people are monitoring themselves for all sorts of things, and it may just be making them anxious and giving false positives for a high cost. So, to finish, Patrick, a few conclusions. Monitoring's common and increasing. Some of it may be unnecessary, like diabetes and over cholesterol monitoring, but some of it works and probably needs better usage, such as INR and maybe BNP monitoring.